It's general practice in a situation where it needs to change. Well, lots of people talked about that for quite a while. And in this episode, we're going to talk about building a better general practice. Is that even possible? Well, we're going to find out for you right here, right now. So let's take in hand to your primary care and learning.
Hello, EGP learners. It's Andy and Gandhi joining you from sunny Nottingham at the moment. So it's all change in the NHS. NHS England is welcoming a new CEO at the moment, Amanda Pritchard. So welcome, Amanda, and we'll extend you an invitation to come on the podcast and show in the near future. So Amanda's starting, but she has a lot in her in tray. So we were going to look at sort of two issues or articles today. The first is Gandhi. Do you want to share the screen? Drum roll. So one of the things in Amanda's in tray is that the NHS has dropped from first to fourth place in the Commonwealth Fund's assessment of the healthcare systems of the rich economies in the world. So Gandhi, if you remember, we were all quite pleased, I think, 2 years ago when they perhaps last published this league table, and we found that the NHS was considered the best or the best performing healthcare system in amongst 11 developed countries that this organization looks at. It's a US based think tank, and they've now published their next assessment of the world's leading healthcare systems, and we have slipped to fourth, which is a little bit sad, isn't it? Shall we just have a look at the main table in their findings? So what's happened, Andy? Why have we slipped?
It's a bit of shift. So UK was typically top, I think, past 3 or 4 times. This has happened since about 2014. And apologies if I've got that wrong. And I'm sure somebody will comment on that if that's the case. But yeah, it's a bit of a drop. And I think there's a variety of reasons why that could have happened. I think, so now top of the list is Norway, followed by Netherlands, and then Australia. And then it's the UK. So not just that we've just slipped, we've slipped 3 places. So a bit of a fall. I think we're going to cover that probably in more detail in another episode. But in terms of the drop, it's a bit of a jump, unfortunately.
Yeah, so sad news. It's been an unusual 2 years, hasn't it? So it'd be interesting to see how the relative performance generally in COVID has affected those rankings. I mean, another thing in the in-tray will be to look at the state of, well, the whole NHS, but also general practice. Prior to COVID, general practice was considered to be showing some cracks in its facade, some cracks in the brickwork, and there was a lot of talk about changing the model or looking at and examining the models by which general practice is delivered. And we noticed that Pulse have been running an interesting series of articles over the last few weeks looking at this issue. They've been running their Building Better General Practice campaign. It's been a really good series of articles, actually. They've had some general discussion articles. They've done a survey looking at the state of general practice and how people feel about the way in which it's run and how it might be run and organized in the future. And they had a panel discussion as well that examined this. And I know we've found ourselves asking similar questions and being involved in similar discussions as the system emerges from the COVID-19 pandemic. We're starting to come up against the same problems we were facing before around workforce, the viability of the partnership model, new and so GPs moving through the system not wanting to enter into partnership, issues around funding, structuring, the size and the viability of organizations, small practices versus big practices. All of these things we're starting to discuss again, or at least that's my experience, Gandhi. Have you been finding the discussions over the past few weeks?
Yeah, it's been interesting. I think partnership has always been a question. Is partnership still the future of the NHS? And there's always been a lot of support potentially from centrally, although that may not always be the perception when it comes to funding. But in terms of how a partnership's going to continue, I think there's been a significant change in the structure, in the kind of way that they're doing that. And, we are seeing, I think, the reduction of the single-handed partnership, which was the model of which the NHS has run for the past, 70-odd years or so. And, we're seeing group practices, different types of practices. And is that viable? Well, it'll be interesting to know, isn't it?
Yeah, I mean, we've been talking about this for a while. I'm going to show an image. I wonder if I can make that bigger. I'll try on the fly. I'm not sure I can. People might have to zoom in. So this was a few years ago now. The local RCGP chapter in the Vale of Trent ran a poster competition one year for their AGM, and I just submitted a simple cartoon. This was back when I used to enjoy drawing and sketching a little bit more. So I did a cartoon themed around Damocles. So people might remember their classics and the character of Damocles, who isn't actually the king. I think I forget the name of the king. Dionysius, I think it says at the bottom here, who's the king. And Damocles was like a court jester, and he always thought, oh, it looks great being the king. There's so much wealth, there's so much riches. Why wouldn't anybody want to be in that position? So he swapped chairs with him, but the wise king had placed on a horse's hair a sword directly above the throne, to signify the sort of constant worry and threat that that one experienced as a king in the in the Bronze Ages, threat of assassination, being deposed, all sorts of things. It was actually not as pleasant as it looked. And I thought that being a GP partner, as I was at the time and still am, often felt a little bit like that. Actually, you get people like the Daily Mail and other sort of news sources, and people really, assuming that it's a fairly cushy job, lunchtimes on the golf course, £150,000 a year, all that kind of nonsense, really. But actually, by both existing partners and people looking at entering the partnership model, we've got Dr. A Millennial here. I don't know when we'll get our first Generation Z doctors or GPs. I don't think they're quite here yet.
No,
so
millennials
are still the new crowd, but they'll come and they'll probably have a whole different set of things and expectations as well. But it can look a bit unattractive being a partner at the moment. I think that's been a problem with the NHS. Just to give people a bit of a history lesson, and I don't want this to turn into a bit of a rant really, but the partnership model is based around the Partnership Act 1890. So it's I think a really Victorian way of running things, almost Dickensian. He was a little bit earlier than that when he did his writing, but you have people really facing difficult liabilities. It's a difficult business structure, and I think from my perspective, this model worked very well, at the beginning of the NHS in 1948, when really it was about 2 or 3 or 4 GPs working together, still actually fairly independently, possibly even with their own lists, but sharing common resources like a building, like a secretary later on, nurses and other healthcare professionals and practice staff. And I think that worked quite well. And I think it was very difficult for a GP practice to fail or get into difficulty in those days. But the environment's really changed recently. We've got a rising tide of patient demand, almost encouraged by politicians potentially, and then there's all sorts.
Absolutely.
There's all sorts of difficult challenges. Patient demand. Without that, people may not understand that a classic partnership, which GP partnerships are, there is unlimited liability for the GP partnerships. So the GP partners. So that means that if there's an issue that puts the practice finances into negative numbers, that comes out of the GP partners pocket essentially. And in catastrophic business failure cases, in theory, that GP partner might have to sell their house to pay business debts, might have to declare bankrupt. And these are the sorts of things which just aren't faced by our colleagues in hospital or our or salaried GPs to that extent. And things have got worse over time.
Standard businesses as well, Andy. It's important to remember most businesses are limited liability partnerships, so that worst case scenario, if something was to happen to the business, the owners of the business don't necessarily have the same financial liabilities that GP would have in terms of a partnership.
That's true.
So that's not to say that there isn't risks, obviously, with limited liability partnerships and things, but it's not the same level of liability, and that's that key word, isn't it?
Absolutely, yeah. With a normal limited liability corporation, an LLC, which is like the most common business structure in the UK, has different names in other parts of the world sometimes. The liabilities stop with the death of the company. Corporation means corp, body corporate. It means it acts like a person. So when that corporation dies, its liabilities die with it. So if you own a limited liability company, then you might lose all of the money you've put into the company. And there might be some circumstances if you've done loan guarantees and things where you might lose additional money, but in most circumstances you just lose the business. You don't also lose your house or your personal finances. And I think there's also things which have made like failure of GP organizations more likely than they were in the past. There's issues around employees rightly have stronger rights. So there's human resources liabilities there now in case of being damages awarded to people in industrial tribunals. There's the real credible threat of practice closure by CQC action. You're exposed to the full market forces of the cost of locums and property fees and 25-year or longer leases that can be difficult to get out of. Gosh, not doing a very good sales pitch here for GP practice, but I just imagined, an old GP partner sort of sat there on the chair saying, "Oh, come and join me, be a partner." And, and we wonder why it doesn't always, not all partnership like this, by the way, there's ways to control all of these risks. And we might talk about that in the future.
Absolutely.
Why would you join that? And I'm not sure. And a lot of people look to, at that time, but Byzantium Health or Babylon Health was a bit more of a thing in the media. And, there were other options for people to work in. So people were turning away from partnerships. So that's sort of my feelings about some of the problems with the partnership model. It's not all bad though, Gandhi. Any sort of, just while we're dwelling on partnerships, any positive aspects that spring to mind for yourself?
I think the key thing with partnership is it's the elements of control and flexibility it offers. So as a GP partner, the business is mine to try and support and run as effectively as possible. And that's both for the benefit of our patients, but also for the benefit of our staff. And there's flexibility that does come with that. Absolutely, there are restrictions in guidelines and rules and all the other stuff that come from up on high. So particularly NHSE have had a massive role in that, particularly over the past 2 years with the pandemic. And as well as the contract negotiations that we're not really part of. So we don't get to negotiate our contract in any way, shape or form. That's done by the GPC on our behalf. And that can have sometimes a interesting impact. And then obviously there's the wider stuff in terms of the local variations that come with that enhanced services and other funding things. But I mean, the basics of general practice is that GPs get paid a capitated amount per patient registered with their practice. At the moment, on average, it's something like about £100 per patient, which, some people think, oh, that's not a lot of money. Well, if you rock up to A&E, A&E gets that just for you turning up once in the year, no matter how many. And then obviously every time you turn up, they get an additional amount, whereas general practices will get that amount to offer you care for the entire year, no matter how many times you use your GP service, no matter how many times you go to your practice for X, Y, and Z. And we don't charge anything more than that because we can't and we're not meant to, and that's definitely sensible and appropriate. There are some additional pots and funding that do come in. I'm being brief, Andy. But then that's basically what makes up the GP income, and they have to sort out the business based on that, including paying all the estate, staff, everything else, and then the partners only get what's left over at the end. And I think that's where a lot of the challenges come from that, because it's the responsibility combined with the level of income versus the liability.
Absolutely. I was just leaning in because we always say, oh, get paid about £150 per patient. And then normally what follows is try and insure your rabbit for that, with a pet insurance company. It is
less than most
good
people
value.
a mobile phone, which many people would say is their one of their essential things in life in terms of communication with others and contact and networking and all that kind of stuff. Your GP practice gets less than you pay for your mobile phone for an average person out there.
Yeah, absolutely. So there are, I guess what we're alluding to is that there's a workforce issue, just kind of backing up a little bit and thinking about the shape and function of general practice, because general practice doesn't just exist for GPs and GP partners to work in. We're an important part of it, as are all the other staff, but it's there to do a job for the patients. And actually, if the general practice sector is not functioning effectively, that's a problem for everybody, because the government needs to deliver effective healthcare to patients, and patients want to receive effective primary care. So I think everybody's got a stake in building back general practice in a way that works and functions. And I think we were sort of the issue around the partnership model is, in order for general practice to actually continue to function, people need to be partners. And the trouble is, a lot of new GP and large numbers of GPs need to be partners, because we have a large number of individual GP surgeries, and the sort of new generation of GPs coming through don't have the same appetite to be partners as they had before. And that's a problem if you want
Mhm.
the system to continue in its current shape, because the two things, they just don't go together. They
No.
can't both be true. Something has to be different about general practice. And I think that's, I guess, where we're heading with this discussion. But just backing up even more, shall we look at some of the outcomes of the survey that Pulse did?
Absolutely. Let's bring it
And
up.
just react to them.
Sorry, there we go.
That's right. I just need to scroll down. So they're asking some big questions about the current state of general practice and the future. And they're asking people on a sort of scale of 1 to 5. So 5 is I agree fully with this statement, and 0 is I don't agree with this statement. And I think we'll take each one in turn and respond. Just a general thing for me here is actually a lot of the questions, the answer's around 2.5, like somewhere in the middle, which I don't think is a very strong signal on the
Okay.
question. Either way, on average, for a lot of these questions, people are neither strongly agreeing nor disagreeing. But there are a few where the signal is stronger. So I think they're the ones that it's worth spending a bit more time on. So, but yeah, I'm going to ask you the answer to some of these questions, Gandhi. So the model of GPs being independent contractor is obsolete. People were on the fence, really, in terms of this. What do you think? Just give me a quick answer.
I think general practice won't function if you don't have GPs being independent contractors. That's my personal view. I think if you move to a completely salaried model across the entire of the country, people work to rule, and it will cost a lot more, and the service will be a lot different. And I know there are people out there that hate the service that they have at times because they feel negative about it, and there's some people that love the service that they have. But I genuinely think that the service will get worse because the funding won't be there to allow that to continue to happen in the same way, shape, and form that it is now. What about you, Andy? What do you think?
Yeah, so in a way, I'm ambivalent about these questions, really. I guess what they're saying is independent contractors. They're saying self-employed partnerships versus a salaried sort of centrally run service. Really, I think is at the heart of this question. I think you're right. I think a lot of GPs might be quite happy actually to be salaried, and that's what a lot of GPs say. They can operate in a similar way to hospital consultants. They work set hours. When those hours are done, their job is done. To some degree, people will still give discretionary effort, and I'm sure they won't leave patients hanging in limbo or at risk. But they'll have much more control over their hours than GP partners do, who just have to work until all the work is done, even if that's staying till 10 o'clock at night on a Friday to clear pathology inboxes, for example, which a lot of my colleagues do a lot of the time. So I think a lot of GPs would be happier. However, one gets the sense that the only reason the system functions as well as it does now, and that is not necessarily meeting people's demands and expectations and needs, is because of that discretionary effort. And if you lose that, like surely it just gets worse. Without more GPs, which aren't there, which is part of the problem with the current system, it'll just get worse. So I think it's better for the patients actually that in the current circumstances we continue with the independent contractor model. But unfortunately, that means sort of burning out more GPs. It's difficult. Of course, you could have an independent contractor model that is better funded and better supported, which I think is probably the answer. Next question. GP practice should comprise small autonomous businesses. So this is about being independent businesses separate from the direct control of the Department of Health and NHS England. And actually, I think there is a weak positive signal here that more people agree with that statement than not, which I think is interesting, actually. Next question is, GPs running a business takes time away from providing clinical care. I think that's one of those statements that just has to be true. They might better ask, is that a good, on balance, is that a positive thing? Because what that means is if a GP is doing some business tasks, what you have is somebody who has to sit some of their time face to face with patients and look them in the eye and face direct challenges about the quality of service, that person is also making resource allocation decisions about how the business functions and how that service is delivered. And that some might say that's a good thing that some GPs do that, even if it takes them away from direct patient care for some of their time. Don't know, what do you think?
I think it's inevitable. Well, it will take them away from healthcare because that's kind of the responsibility and the role that they would have to do. Otherwise, you can't be in two places at the same time. It's a bit of a slightly disingenuous question, I think, but I think, is it that it has a detriment to the healthcare service being provided? I think the question needed to be clearer, to be honest, from my perspective. But yeah.
Yeah, I'm going to ask a controversial question here to you, Gandhi. So what we're seeing, so in an effort to attract and keep more people in general practice, we're seeing a lot more roles that blend clinical activity with further education or management or leadership activity.
Okay.
A lot more roles, like loads of them. And the result is that people who might have done more.
We've got
lots of fellowships and things.
Got
that's been seen as a way of keeping people in the profession and so forth. But what you end up with is people who do less clinical work than they perhaps otherwise would have done. And I just wonder if this is the wrong, just a question, is this the wrong sticking plaster? Is taking more people away from, is finding, leadership and educational roles for people to take it feels like, to me, I'm going to be really controversial, some of this is about resting people from the clinical job and actually allowing them to do like a 3/4 full-time post, but paying them a little bit more to keep them in that post, and it's a bit like when you have armed forces, they can't be at the front line all of the time. You've got to rotate them out, otherwise they just burn, and you can't, and they're useless. And I just wonder if actually this is just treating a symptom of just what general practice is like, and actually what we're doing is resting the troops and just not sending them into the battle as often. I don't know. Controversial. I'm not even sure that was a question, Gandhi. Do you agree with
the nail on the head there, Andy? I think that's the reality of the situation, that you and I have both said that full-time general practice is no longer 10 sessions. It's not 9 sessions. It's not even 8 sessions. 7 at a push, in terms of 3.5 days of clinical workload for most people. That is their absolute limit they could ever imagine doing nowadays. And to do stuff in the other time is not patient-facing roles. I think the number of GPs that are doing more than that at the moment is reducing rapidly, and especially those doing partnership roles at that level is massively reducing, because it's you just can't maintain it. So the fact that they're creating roles that have other things baked into it, I think is a positive thing. But you're right, it means that the numbers don't mean what they say that they are, to the same degree. So I think there was an article recently, I think it was just the other day or so, talking about the increase in GP numbers, but actually when you look at the whole time equivalent of clinical care being offered, that's not really increasing significantly at all, and probably actually reducing, as you mentioned, because of this whole issue. And then when you chuck into things like supervision of the RS roles into that and all the other things that are coming through, I think it's actually going less and less, because the reality is it's just not funded to provide that. But hey, controversial view as well.
No, absolutely. So let's concentrate on the ones where there's a positive, strong signal. Just there's not that many additional questions. It is possible to have GPs working in autonomous small businesses and providing adequate clinical care. So it's really saying is small autonomous business units, as is the norm for general practice, consistent with providing good clinical care? And overwhelmingly, people are saying that that's the case. Interesting to note just that they're broken down by age level, although not with much granularity. So, for example, the 25-year-old GP, yep, you heard me right, the 25-year-old GP is sort of placed in the same bracket as the 44-year-old GP. That's somebody who isn't a GP yet. Can you be just about an AIT at 25? I'm not even sure you can.
You finish uni at 8, so you go to uni at 18, 5 years minimum medical school. That takes you to 23, and
you can be an AIT.
Yeah, that's not possible. Yeah,
you can maybe just be
you could literally be on the door of being an AIT GP trainee. Yeah, you could be an ST1 GP trainee potentially at the age of 25.
But anyway, quite broad age categories. But nice to see we're both still young GPs. Still, just hanging on. But they're actually more positive on this question than some of the older GPs, which I think is good. And then let's just look for another one with a strong signal. So this one has a strong sort of don't agree with this statement signal. General practice should comprise of bigger businesses with the majority workforce salary to private organizations. And the really interesting thing here is people at the beginning of their career who you might have felt wanted to be salaried to large organizations, like this idea, the least, which I think is quite interesting.
It is. So I think most people would have thought the exact opposite with the whole, like you said, millennial perspective coming through and stuff. But actually, it seems it's not really the case. or less of a case?
Yeah, no, absolutely. I think talking to people, often what people want to do is they want to be a salaried or locum GP for a partnership, and they find that actually that's their preferred way of
Yeah.
working, particularly at the start of the career. Which also means some of them will eventually have to be partners in order for that to actually square off and work. And that I think that's really the end of the strong signals there in that survey. So just on the question of how do you feel about this question of, so we've put a question mark on the partnership model that we're going to have to square off somewhere later, perhaps if we're generating some ideas in this discussion. There's another question around small, medium business model. So I suppose what we're saying is currently we have small and medium-sized enterprises. These are organizations that employ, less than 100 people, often less than 50 people, often less than that. Small businesses. Contrast that with what I might call larger organizations. So that's like NHS trusts, the type of organizations that might run hospitals or really big chains of GP practices, for example, or large international corporations and companies, potentially. We're sort of contrasting those two things. You've got partnership or not partnership, and then you've got bigger or smaller, which I think is another question. Where do you sit on that ideal size of organization issue, Gandhi?
I think when you get organizations that are too large, then you have more challenges in terms of understanding the structure and the progression for the individuals themselves. And you need to have really good, strong leadership structures for that to work effectively. I think being too small is a challenge because it's the responsibility that puts on you. So, I would argue that a good size of a practice would be anywhere between 10 to about 15,000 patients, and ideally to have at least 4 to 5 different people coordinating that as potentially partners or whatever that is, so that you've got good depth and resource to lean on that. And then obviously support structure around that to enable to make sure that those 4 or 5 people have the capacity to work effectively. And if you're scaling up, then you need to scale up everything. It's not just, that those 4 and 5 people then become in charge of a 25,000 patient organization or something like that, because I think that's when it gets challenging, or you kind of have to add levels if that's the case. That has happened in some places. So there are some super partnerships that probably still have just a few GPs at the really top of this pyramid structure. And is the pyramid structure something that we are having to think more about, and what does that structure look like? So we've got examples like the Hurley Partnership, Modality, other kind of organizations like that have very different ways that they do things, but similar sort of larger structures compared to practices like mine and yours, which are very much the small enterprise level, compared to single-handeds, which are the smallest of the ones that you can have. What do you think?
Yeah, I think you make a lot of good points there, Gandhi. I think I really want to add rather than duplicate what you've said. I mean, but at the danger of duplication, I think the bigger you get, I think scale brings economies of scale, but I think it also brings problems. I think the distance between the decision makers becomes greater. So you go from a situation where if you've got a sort of small or medium-sized practice, say 15 to 20,000 patients, the leaders of that organization are still going to be doing sessions within that organization, particularly if you have clinical leaders. So they're going to have to sit in the same room as the patients on a week-to-week basis, look them in the eye, and and answer the challenges about the quality of service and access and things like that. So they'll really understand what is happening, and I think that'll be reflected in the decisions that they make. Similarly, they've got to sit in the staff room with all the other staff as well, and make when they're making decisions that affect those staff. That's going to influence their decisions, and I think you get better working environments, and I think you get sort of more responsive care for patients, provided they're big enough to be stable and sustainable, and allow people to specialize in leadership and afford good quality management and leadership. So I think there's a sweet spot, I guess, is what I'm saying, and it's somewhere a little bit bigger than the smallest practices that we have now. But I think if you get too big, then you end up with the decision makers being in London in a corner office somewhere, and the distance is just so great that they start to the proximity of the decisions that they make is just so far removed from the people they're serving that it's going to sort of dilute it a little bit. That's my feeling on scale. So I think bigger, but not huge.
Not too big.
Is probably best. I think what used to work quite well, and I didn't live in this world, Gandhi, but I got the sense that general practice used to be a bit more like small business units, but really well supported by their primary care trust or local health board or whatever it would have been at that stage, and that actually they were a small business unit, but there was more support and less risk on them as a small business unit, and they got on with doing the care of the patient and didn't have to worry so much about business risk. So yeah, that's how I feel about scale. And I guess over the years, Gandhi, we've experienced a number of ideas to increase the size or the scale at which general practice is delivered. And I know in my sort of 10 years as a partner, there've been various things that have been the answer to restructuring general practice. We talk about mergers, just getting bigger through mergers, and those happen. And sometimes they're difficult. Sometimes they work very well. The development of super practices or super partnerships. There's a few ways those can be organized. We've seen those emerge in different parts of the country, not really locally in Nottingham. There's federations, which were quite big a few years ago, and we have a large federation in Nottingham and a number around Nottinghamshire. And then most recently, primary care networks, which is another example of doing things at scale and trying to get that compromise between too small and too big, and setting that number at 50,000 patients. So yeah, we've lived through a lot of things already, I guess, and that won't be the end of the journey.
Well, we're kind of going even further now, aren't we, with the introduction of ICSs and ICPs underneath them and stuff. So there's various different structures around and incorporating a lot of that and the change that comes with that, which is yet again another challenge. It's the change, I think, that makes this so much more frustrating. But
yeah. So what is the answer? It's very easy to talk about the problems, and it's very easy to sometimes it's easier to think, well, if we had a blank piece of paper, what would general practice look like? But we don't, because we have a current situation and we have to transition from where we are now to wherever the destination is. So maybe with shall I give you my manifesto, Gandhi?
Go for it, Andy.
What I think, given where we are and where we need to get to, I think where we need to get to is bigger, and we need to do something about the lack of availability of willing people to be partners and the right people to be partners. And I think those are the main things. What we haven't talked about so far today is funding, which I think is an enormous issue and is the reason why a lot of the problems that are there. But we're talking about structure today rather than funding. So I think we need to go through a process where the organizations get a bit bigger. And I think that will and is involving the handing back of some contracts from some of the smaller, the smallest practices as people retire, or the merger of those organizations, or their merger into larger organizations. So I think things will get a bit bigger. I think fewer people want to be partners, and we just need to accept that, I think. But I don't think that's necessarily a bad thing, because we might move to a system where we have fewer but sort of specialist partners. So some GPs are interested in organizational change and leadership and some of the management aspects and service design. Like the two of us. And, and we are partners at the moment, and we've been partners for a number of years. So there's obviously something about it that attracts people like us to it, but turns off other people of our generation, because we're old, but we're not that old. And a lot of my colleagues are still locuming or salary GPs. So I think there's space for fewer specialist partners in bigger organizations. And I think a lot of the problems around organizational failure actually start to disappear when you reach a certain size that isn't that big. I think once you've got 6 or 7 or 8 or a few more partners, actually that last man standing risk, and it's well-organized organization and it's sustainable. You sort of remove that last man standing risk, which I think is an obstacle to some people joining. So as it's easier to exit, it's also easier to attract people in because they know there's a way out, the partnership. And those people can really specialize and train up to be specialist leaders in general practice. And there will be other people who don't want to be partners. They might be a lot more of them, and they can specialize in the more clinical aspects of the job. And I think it's important that we provide those people with a career path. So they might start as a new GP, move forwards and take on additional clinical or organizational responsibility, might become an associate of this or a lead for that, and work their way up. And there's a pathway up to partners. I think if the partners are still taking an elevated level of risk, then I think that also that needs to be rewarded in some way, and there needs to be an aspiration to move up the career structure and continue to educate yourself. And not all partners, some partners will have clinical interests as well, but I think they will be interested in running the organization. So I think that's helpful. I think a change from unlimited liability 1890 Partnership Act partnerships to something more modern like LLPs, which is how a lot of the like accountancy and law firms are run, that still has a partnership model but limits liability to individual partners, would be a great move. I'd like to see GMS and PMS contracts be able to be held by those sorts of organizations. And then I think you then probably need a layer of cooperation of those bigger organizations. I think there's still a role for primary care networks and federations above that. That's the sort of thing that I think will modify. I think it's achievable from where we are now to move towards that. And I think it might be the natural progression given the circumstances which we find ourselves in. I don't know, what do you think, Andy? What do you think the future is?
I think the future is evolving. So a lot of this was obviously discussed in the partnership review done by Nigel Watson a couple of years back, just before the pandemic, and a lot of the outcomes from that mirrored some of the comments that you made. I think unfortunately COVID came along and detracted from the discussion on that, like it did with other elements of the NHS England's plans, like the long-term plan and that kind of stuff, and the PCNs even. They've obviously directed their focus away from what the plan was, the PCNs, and more towards supporting the healthcare of the population, vaccinations, all that kind of stuff. I think the first thing I would probably suggest that we assume against it is the fact that, or basically you can't assume anymore that partnership is the end point of a GP's career. Because if you go back years, that's what it was very much seen. It was seen you finish training, you locum for a bit, you become salary for a bit, and then you become a partner. That's absolutely not the case anymore. Partnership is a portion of the portfolio career that people go into, and not everybody's cut out to be a partner. That's the first thing I'm going to say.
Or wants to be a partner.
Yeah, I think that there are always going to be people who want to be a partner and not designed to do so, and there are people that are probably partners out there that definitely should not be partners, and there's absolutely going to be people that get into the right boxes as well in terms of where they want to be and should be. Because at the end of the day, partnership is the way that the business is run based on the ideas and innovations of the group of people there. So you have to kind of get on. Often it's commonly said that getting in and out of a partnership is more difficult than a marriage, in comparison and stuff. I think we're going to see changes in structure, and I think we need to. So you mentioned accountancy and law firms moving towards structures like that. I also see the argument against going to LLPs, because one of the things that's always concerned people is the fact that because it requires a single individual to hold the contract, that's the thing that stops private businesses from being able to hold GP contracts, because it has to be held by a GP as an individual. So the risk is the reason why businesses don't tend to do that. Although, having said that, since then they've created other vehicles like APMS contracts and other kind of organizations that mean that could be held. So I think that's more of a moot point, but important to remember that's potentially always been the reason why they've flagged that GP general practice should not become a LLP or LLC, like you mentioned, in terms of structures and things.
I think LLPs offers some protection from what you're talking about. LLC definitely a no-go. Well, there'd be some unintended consequences of an LLC. LLPs, I think might be the middle ground that we're looking for. Maybe.
But I think what most practices need to consider is the structure of what does the partnership actually look like. It needs to be somewhere that wants people to work there. You can't have a business whereby you've got 2 or 3 people doing all the responsibility and the work, and then they've got a workforce underneath them just doing the clinical things, because that's not sustainable. You don't want a situation that's similarly as well where the employed staff are doing all the work and the partners are just sitting around just in board meetings all the time, because that doesn't give them the exposure to the coal face, and also doesn't give them, like you say, that engagement with the rest of the staff and everything else to understand the implications of their decisions and actions and stuff. Is the compromise working towards this weirdness of a salary partner, a combination of the two, or associate partners possibly. But I think it needs progression with that. It needs to have a structure to say that actually this is where things can move forward and how you can move forward and that kind of stuff. And I think seeing that
Gandhi, what is an associate partner?
So, I mean, there's different versions of it. And like I said, some people call it the salaried partner role. So, whereby you are employed by the practice, but you take on either additional clinical roles or non-clinical roles. So, like, for example, you could be the safeguarding lead for the practice. You could be the, IT lead for the practice. You could be the educational lead for the practice. You could be the COPD lead for the practice. That's the really basic version of it, where you've just got additional clinical responsibilities and you don't receive any of the profits of the practice. The more proper associate partners, whereby you probably have a fixed salary of, say, X amount per month, and then you get a proportion of the profits on top of that. So kind of like a bonus, if that makes sense. And that's based on how well the business does. And that's basically how, I mean, partners are paid on that basis, aren't they? As we said earlier, partners are paid based on whatever's left over once you paid for all the outgoings. The share of that surplus is what the partners get as their salaried. And some places will do that on the basis they get a regular monthly income and then they just share the leftover at the end of the year and hope that it's not negative, because if it is, then they're paying that money back. And that's happened. We know that's happened. That's happened to colleagues of ours. That's happened nationally. We know there's been practices where partners have had to put in significant potential sums of money back into the partnership to keep the business running, so the staff aren't made redundant and so the practice can keep serving its patients. And that's not recognised by very few people when that's happened, unfortunately.
Okay, that's what I thought. So it's just it's limiting some of the risk for that individual in terms of being but also capping the income. So if the practice does perform very well financially, then they only get a lower share of that of the partnership profits. So there's still an aspiration to become a full partner, I suppose, in the future. It's going to work for some organisations, not for others, isn't it? And individuals.
I don't think it will work everywhere. And I think, again, it comes down to the ethos of the practice. That's the thing that determines a lot of how and why these things work. Where
probably, I would say it's probably predicated by GP partners earning more than salary GPs, which is not the case in all places everywhere. I think that has to be the case before you could probably consider that model. Sorry, I interrupted you, Gandhi, and I've forgotten where you were.
So yeah, I guess we're talking about the way you could change things to make things more effective. So we talked about the LLP concept. We talked about different structures and things, and we talked about recognizing that not everybody has to or wants to be a partner prospect. I think one of the things we are going to see with the shift towards federations and PCNs and that kind of stuff, we are going to see this kind of cross-practice structure of organization, and we see that in larger companies. Private companies that sometimes do is they have a clinical lead for either one or multiple practices that kind of runs the situation kind of like a partner, but they're not actually a partner because they're still an employee of the organization. Is that just an alternative way of saying salary partner? Is that an alternative way of saying associate partner? Maybe.
I think they tend to call them things like clinical directors, don't they? Of different regions and things like that.
But this is more hands-on in terms of the way the practices run and function and organization in that respect. And is that something that we're going to see increasingly more so? I know of some chambers, for example, where locums will take on that kind of role. So they will take on within the chamber structure the organizational lead for, there'll be safeguarding lead for the chambers. There'll be learning lead for the chambers, clinical lead for the chambers organizations. And actually, that seems a bit weird to some people, because how can that work for locums who may not be in the same practice? But it's about the structure of support and engagement that happens. And that, I think, can work regardless of chamber structures, federation structures, practice structures. Actually, as long as you've got buy-in to the concept of how that works, engagement, why not go for it? Works in some ways.
So I guess we're coming towards the end, Gandhi. So do you think the future looks bright for general practice going forwards, or is it bleaker? What do you see on the horizon for general practice?
I think the biggest challenge still for general practice is it's got three key issues that need to be overcome. So number one is the fact the workforce is gradually declining. Even though they say that they're churning out more GPs, more of those GPs are not working full-time or whole-time equivalents. They are working less and less towards either 3/4 time or half-time. So actually the numbers aren't going up. So the workforce needs adjusting. And does the PCN des and the workforce from the RS roles help with that? In some ways, yes, and in some ways, no. So it's not necessarily the savior to that mechanism. Number two is workload. The workload is exponentially increasing based on both patient and governmental expectations and the complexity of the work itself. The type of work me and you are doing now is completely different to the type of work we were doing 10 years ago, when we were training and stuff. So, and, our more senior GP colleagues will probably say, that what they do now is so much different to what they used to do in general practice and how you could run things. And people, particularly the media, like to harken back to the old days of Dr. Foster going around to do a visit, every single patient. That's not doable. Let's be absolutely clear. That is just not possible anymore with the way that the workload is. And thirdly, estates. The estate solution needs to come through in some way, shape, or form. We just don't have viable regular estates across the country to deliver effective primary care. And if that's not looked at in some way, and does tech help with that? I think it does in some ways. But is it the only solution to it? Absolutely not. There are other solutions that need to be considered and looked at because we just don't have the physical space to see the patient demand that we're currently dealing with. And until those three issues are looked at, dealt with, and underpinning all that, which I know we said we weren't going to talk about, is the funding to enable all that to happen. But yeah, that's my view. What do you think, Andy?
Well, is the future bright or not? I'm going to give an answer which sort of sounds a little bit bleak, but I think it's a little bit stoic in a way. And it's about locus of control, and it's about stress management and making our own lives more sustainable. I think because we've all got to keep working to keep doing the job of looking after the patients, and got to keep going till we retire as well. And I think there's only so much that so many of us can control, but we do have control over that. So there are people who can tackle some of these big issues, and we can all support them. The people getting the right people negotiating for us at the GPC, the right people representing our organizations at the RCGP, and so forth. So I think it's really important to be engaged with the issues, but you can become quite despairing if and you can get yourself in quite a dark place if you get too involved in thinking about all of this. So over the years, as a self-protective measure, this isn't quite an answer to the question you're asking, but I'm just running with it. I've come to think of delivering primary care a little bit like failing gracefully, because it's a bit like aging gracefully, because I think with healthcare, like, you're always fighting a losing battle. By definition, you cannot fight the aging process and the disease process, and unfortunately, the end outcome is inevitable for everybody in terms of healthcare. And that means there's only so much that you can do to run primary care effectively. There'll always be more you can do, more hours you can work, more that you can put in that will have some effect. But there's a limit to what you can do, and there's a limit to what you can control. And I think the best that we can do is look at our individual situations, the cards that we've got, the situation that our organizations find ourselves in, if we're in a decision-making position or position of influence within that organization, and just play the best game you can with those cards, to do your best with the resources that you've got available and be able to say that you have done your best. And I think then you can hold your head up high. So I think, and if you do that, no matter what the future looks like, it starts to look a little bit brighter. So that's just a reflection of how I've shifted my mindset a little bit over the last few years in a defensive way. And so that leads us to say, yeah, I think the situation looks both bleak and bright. It's real. We'll get there. We won't be happy when we get there, but I think there's an arc of progress, and we'll get to somewhere better than the situation that we're in now, I think.
Hopefully. And I agree. I think there is some positivity coming through. One of the things I really have enjoyed and looking forward to is the additional support for those wanting to take on partnerships, those new GPs and that kind of stuff. And there are structures around to help with that. So people do want to check out one of the ones that I'm part of, and massive declaration I'm part of this journey. And that's the team of Medics Money, who are looking at providing new GP training courses that's available to help people understand partnership, because we didn't have that when we started. We kind of learnt on the job, and we had I had a couple of mentors, senior partners in my organization and people outside of the organization to help me learn a lot of this stuff. I'm guessing you had similar, but that
Yeah.
process takes years, doesn't it, to understand properly?
It does. Yeah. And to be fair, I think partnership is and can be attractive.
Mhm.
But you just have to make sure that you're educated going into the role, and make sure that it's a partnership with the right people.
Mhm.
That's really, really important, that you all
Yeah.
get on and have similar values, and at the right organization. So it's sort of an exercising in sort of controlling the
Mhm.
risks, be that people risk, clinical risk, financial risk, organizational risk. So people need to educate themselves. So I think that course is a very, very good idea.
Absolutely. And if people do want to find out more about it, check out this video here that I did with Tommy Perkins, who kind of created the course and stuff. And as I mentioned, I am part of that. So massive declaration there. And as always, if you do want to check out the links and stuff, they'll be down in the description below. And we will always be here to help tech enhance your primary care and learning. And we will catch you in the next episode. See you later.